Hi, everybody. Welcome to today's Student-Led Journal Club case study with the MKRC. My name is Anne-Marie Parker, and I'm a research associate at the Joplin campus of KCU. And today I will be introducing our speaker, student Dr. Ryan Schiller. Student Dr. Schiller is currently completing a fellowship in anatomy through Kansas City University. He is between his second and third year of medical school and will be continuing his clinical education in Wichita this summer. Student Dr. Schiller previously earned his bachelor's degree in physiology and kinesiology from the University of Florida and a master's degree in medical science from the University of South Florida. He is also enrolled in the DO MBA dual degree program with Rockhurst University and will complete the MBA portion next summer. He is a member of the surgical specialty track and hopes to pursue a surgical specialty in the future. His research experience includes volunteering in a Parkinson's/movement disorder lab during undergraduate and assisting with several of the other fellows' cadaver projects over the past year. So with that, I will hand the floor over to you, student Dr. Schiller.
All right, thank you very much. So first of all, thank you all for being here, and thank you to MKRC and everyone involved with that for allowing me the opportunity to share my research with you all. And lastly, a huge thank you to everyone listed on this screen for helping me complete the project. And this is my abstract that should have been sent to most of you earlier for your convenience to look at. So first, a little background and intro to something known as lateral rotatory knee instability. It's basically an instability of the knee where the tibia will rotate either anteriorly or posteriorly on the femur. This can occur and come about after knee injury or after a reconstruction. With the posterolateral rotatory instability, it mainly involves the lateral collateral ligament, or the LCL, as well as the arcuate ligament and popliteus muscle and tendon. For the anterolateral instability, it's chiefly done by the anterior cruciate ligament, or the ACL, as well as the anterolateral ligament, or ALL, and the IT band. Much has been made of the anatomy and function of the ALL since it was discovered as we know it today back in 2013, and there have been several studies that established its function as a secondary stabilizer of that internal tibial rotation on the femur. And other than the ACL and LCL, a lot of injuries to some of these structures can often either go undetected or just elected not to be reconstructed during a larger surgery for something like an ACL tear. And this is a diagram of all of the instability patterns of the knees. Some that you'll probably be familiar with are anterior and posterior instability. That's basically like that anterior posterior drawer test that we use to test for ACL or PCL deficiency. But the ones that we're focusing on are this anterolateral and posterolateral instability, where this lateral portion of the tibia is either rotating anteriorly or posteriorly on the femur. So there's been several studies that look at this rotatory instability and these ligaments that are involved with it. One study showed that women experience more instability after an isolated ACL tear and reconstruction. And there has also been a lot of sex-based studies on the differences between male and female of the ACL and ALL respectively. Additionally, there were two other projects that correlated the ALL thickness and length with that of the LCL and ACL respectively. But some gaps in the current literature include laterality differences because a lot of the large samples in some of these studies weren't matched to be able to study right versus left. And those that were matched were generally small sample sizes, or they just didn't look into potential differences in right versus left. And as well, while there are sex-based differences studies of some of these ligaments in isolation, the degree of these differences or how all three of these ligaments relate to one another as part of this rotatory complex, these haven't been studied for any sex-based differences. So the objective of this study was to investigate differences in the relational anatomy among the ACL, LCL, and ALL with respect to differences in sex and laterality. And secondary objectives were just to add anatomical reference data to the anterolateral ligament, since it's relatively new in the literature. And this Gertie as a consistent landmark used to locate its insertion point. And this is my hypothesis. Basically, if lateral rotatory instability involves these ligaments and women experience more instability, then there should be significant sex differences in the relational anatomy of these ligaments. So once again, just looking at the anatomy, we can see the ALL over here and the LCL labeled with the fibular collateral ligament in this diagram. But also I want to point your attention to these distal capillin fibers on the deep side of the IT band, as well as the capsulo-osseous layer here. These structures can be confused with the ALL during dissection quite often because they're very close to its origin point, and in the case of the capsulo-osseous layer, overlying the ALL. So the dissection that we used for the LCL and ALL followed that described by de Lima, because this technique documented the highest success rate for finding both of these structures. Different techniques for dissecting and finding the ALL have ranged in success rate from 100%, as de Lima demonstrated, to all the way below 50%. So we chose this dissection technique because it had the highest success rate. And so this involves bisecting the iliotibial band 8 to 10 centimeters proximal to the knee joint, and then dissecting it distally, being very careful not to damage any underlying structures, such as the ALL. And once this is done, the LCL is identified just anterior to the insertion of the biceps femoris muscle, and it's then isolated. And occasionally during dissection, the biceps femoris muscle had to be cut along its insertion so that the insertion of the LCL on the head of the fibula could be properly identified. And next, after the LCL is properly identified, the ALL is then looked for by applying a slight varus and internal rotation force to the knee. These forces combined just really isolate the ALL fibers in a straight pattern so that it's easier to see where they're at. And generally they're lying superficial to the LCL in somewhere along its proximal 1/2 before the knee joint. And so both ligaments and their origin and insertion are isolated and pinned. And then also the tubercle of Gertie is pinned at its most prominent point, as you can see in this image. And lastly, for the ACL, the patella is reflected superiorly, and the patellar fat pad underneath is resected so that we can see the ACL. And so in terms of measurements, the length, width, and thickness of both the LCL and ALL were taken at full extension of the lower extremity, with the latter two, the width and thickness, taken at the level of the meniscus, so about midline in the joint. And additionally, the distance from ALL insertion to that tubercle of Gertie was assessed. For the ACL, the length and width were measured at 120 degrees of knee flexion. And all measurements were performed by a single investigator using a digital caliper to the nearest 10th millimeter. So the sample that we looked at was 41 formalin embalmed cadavers, 20 of them being male and 21 being female. The sample was predominantly elderly and of white race, but there was a good range of both height and weight. And along the dissection, several ligaments were excluded due to things like deformity, total knee arthroplasty, or severe osteoarthritis. And one ligament, being a female ALL, was just not found during dissection, but the rest of them were. And you can see the numbers of remaining ligaments that we studied in the corner. So this was a descriptive lab study, and we chose to do this new dissection with this new sample as opposed to something like a meta-analysis of previous studies of these ligaments, due to that variability in the success rate of the ALL dissection, and also just different styles of dissection, and the fairly recent past disputes over the exact anatomy of the ALL itself, because it could be often confused with some of those overlying structures like the distal capillin fibers. And the statistical analysis included descriptive statistics of all of these measurements that were taken, including relational values of all three ligaments, volume or area associated to one another. And the differences in laterality and sex were assessed using a t-test. So these are just kind of the results of the demographics of our sample. Like I mentioned, it was an older sample, average age being about 77 and ranging from 55 years to 93 years. The height ranged anywhere from 4 foot 10 inches to 6 foot 2 inches, and the weight ranged from 95 pounds all the way to 250 pounds. And males generally were older, taller, and heavier than females. And here are the descriptive statistics of all these measurements that we took. All the measurements had a normal distribution as judged by the kurtosis and skewness of the data. And males generally had higher average ligament measurements for most of these measurements. And you can see here the LCL was generally like longer, wider, and thicker than the ALL, for example. Gertie was pretty consistent across the board. And so then we took those descriptive data and we separated them into right and left and did a test for difference in laterality. So first we did an F test for equal variance for all of these numbers. And you can see that none of those came back significant. So all of the values between right and left had equal variance. And you can see with the t-test as well, none of those came back significant. So there was no difference between the right and left side for all of these direct measurements of the ligaments. And much like we did with right versus left, we did the same thing with male versus female, separated them and then did the F test of variance. And now you can see that both the length and thickness of the ALL did have unequal variance. So when it came time to doing the t-test for those, for the ALL length and thickness, we did a type 3 t-test known as a Welch test, which is used for samples of unequal variance. And all the other ones that did have equal variance, we used a pooled t-test or a type 2 t-test that's used for samples with equal variance. And here we can see the results of those t-tests. So basically the significant ones were everything for the LCL, the length, width, and thickness were all significantly larger for the males as opposed to the females, and also the length of the ACL as well. And then for the relational anatomy, what we did first was we made sure that all of the measurements were from the same donor cadaver. And then we calculated either a volume for the LCL and ALL or an area for the ACL since we didn't measure the thickness. And we established either the volume or area for all these measurements, all these ligaments from the same cadaver. And then we created a ratio that showed the comparison and relationship of these ligaments to each other. And every ratio was for a single donor cadaver. And then we took all those ratios and we separated them into both male and female and right and left. And when doing laterality, made sure that it was both the right and left side of that same cadaver to see if there was any differences between how these ligaments related to one another across those different variables. And you can see here that there was no difference between right and left with these relationship values, but for male and female, the males had significantly more LCL volume in relation to the ALL volume and ACL area than the females did. And it was nearly 2 to 1. And a lot of that stemmed from how greatly the LCL was statistically significant in all of those measurements. So when you relate the ligaments to one another like this, the males had significantly more LCL volume in comparison. And this is just a visual demonstration of that. Here we have these kind of pseudo 3D cylinders that represent the average ALL and LCL for males and females respectively. You can see with the ALL, the males were slightly longer and thicker, but it wasn't significant. And you can see that there's not much difference between the two on this side. However, for the LCL, the males were significantly larger in every measurement longer, wider, and thicker. So when you have the two next to each other, you can see here how much bigger the male LCL is in comparison to the female. And when we move these ligaments to do the relational aspect between the two, you can see how much of an impact that difference in the LCL and female had when we relate it to the other ligaments as part of that lateral rotatory complex. So the males had nearly double LCL volume in relation to their own ALLs and ACLs than the females did. So just starting the discussion out generally with the dissection of the ALL and its origin site anatomy. Like I mentioned, there was only one ALL that we did not find during the dissection. So this was a 98.8% success rate for finding the ALL. And in looking at its origin site anatomy, 78 out of those 80 originated either at or proximal to the LCL origin on that lateral epicondyle and crossed superficial to it on its way to its insertion. But 2 out of the 80, they originated and crossed deep to the LCL. And interestingly enough, these were both in a male cadaver who was at least 6 feet tall and on their right lower extremity. And there was a previous study that had noted this variance with a similar rate of occurrence, but they did not include any demographic info when it came to this variance. And then the ligament measurements that we took, they were all consistent with previously reported data, except for that of the width of the anterolateral ligament. Ours came out to be 3.3 millimeters on average, whereas previous studies, it had only been as low as 4 millimeters. But this could stem from a difference in many things, such as the sample, whether they're formalin embalmed or fresh tissue, the dissection technique that was used to identify the ALL, and also the joint angle during measurement. We measured our ALLs during full extension, whereas previous studies have measured them at varying degrees of flexion or also with that varus or internal rotation of the tibia. So this could affect how the measurements come out. And in terms of laterality, there were no differences in laterality between any of the ligaments. And this just suggests that injury to or instability of any of these ligaments should be evaluated and treated equally on either side, regardless of leg dominance. And when looking at the differences in sex, the males had significantly longer ACLs and significantly larger LCLs all around. Previous studies had demonstrated that there were sex differences in both the length and thickness of the ALL. We did not find that with this current study, but as I mentioned, with kind of the varying factors in our ALL width, differences in the sample, the dissection technique, or the measurement technique could attribute for not finding sex differences in the ALL in this current study. And then in terms of the relational analysis, males had this nearly double LCL volume in relation to their other ligaments when compared to females. And unfortunately, we weren't able to measure the thickness of the ACL in this study. So this could, and we had to compare its area, whereas the other ligaments, we were calculating volume. So this could have affected the results of this relational analysis when the ACL was involved. However, that doesn't play a role in comparing the LCL volume to the ALL volume between male and female. And also, there were no laterality differences in the relational analysis, just how there weren't any laterality differences in the straight up ligaments themselves. So these results could have several implications, from injury susceptibility to this lateral rotatory instability differences that we see between males and females. Females have been widely reported to have an increased rate of some knee injuries, such as ACL tears. And it has also been suggested that that unhappy triad of ACL, MCL, and meniscal damage might often also include undiagnosed damage to anterolateral structures, including the anterolateral ligament. So males having this added relative LCL volume to their other ligaments may help explain these differences we see, their fewer injuries and less instability compared to females. There was a study that demonstrated that ACL volume was inversely correlated to and highly predictive of knee laxity. So it could be that LCL volume is a factor in knee laxity overall as well. So having this added relative LCL volume may provide men with a higher resistance to valgus forces, or just change the way that traumatic forces are distributed throughout the knee joint. Other factors that have been attributed to such differences as what we're describing here have been muscle imbalance between males and females, as well as a difference in the quadriceps angle and anatomy of the intercondylar knot. And these results could also have an application to surgery. The ligament dimensions that we measured and that relational association between them with males and females can help guide graft size, especially when it's coming from a cadaveric source. And not having any difference between right and left suggests that every knee injury should be treated the same, whether it's their dominant leg or non-dominant leg, and that undiagnosed ALL injuries should be assessed equally on both sides. And then lastly, looking at the tubercle of Gertie as a surgical landmark, it can be helpful, but not incredibly reliable. The positives are that it was consistently an average of 24 millimeters anterior to the insertion of the ALL, and that was for both right and left sides and for males and females. And that also matched up with a previous study, 24 millimeters anterior. However, this ranged anywhere from 13.5 millimeters all the way up to 30.1, and it was much more variable in our females than in the males we studied, and it also didn't correlate with height. So it might not be that good of a predictive source for locating the ALL. So in conclusion, these sex-based differences in the relational anatomy of these lateral rotatory knee ligaments, and namely that added relative LCL volume for men, may help explain the sex differences we see in injury susceptibility and post-surgery instability of the knee joint. Some strengths of this study included having a larger sample that was also matched for right and left, as well as the high success rate that we had for finding the anterolateral ligament during our dissection. Some limitations of this study are not having a very diverse sample in terms of age and race, the measurement technique that we used, using the digital caliper, and also not being able to include ACL thickness in our relational analysis, because in order to measure the ACL thickness with digital caliper, we would have had to destroy the knee joint. Some future studies in this area could include repeating this study using either fresh or teal cadavers, or using an imaging study from MRIs to measure the volume of these ligaments to study how they relate to one another in a more diverse sample. Also, you could test how these relational anatomies of the ligaments affect the biomechanical stress and strain of these ligaments. You could do that as a study. And also, since we saw that variance, the variabilities of the ALL with 2 of the samples running deep to the LCL, any study that includes the ALL in the future could do a thorough description of these anatomical variances with respect to sex, height, and laterality, since we saw both of them in a tall male on their right side. And these are some of the prospective journals for submission of this project, and then my references here. And thank you very much. Are there any questions?
Thank you so much, student Dr. Schiller. That was great. Like you just said, does anyone have any questions? Please feel free to raise your hand in the Zoom, or if you can't unmute, feel free to type it in the chat too, and I will get to that and read that. Dr. Joy, I think you had your hand up first.
So, inviting an osteopathic physician to this is maybe a little on the dangerous side. But I've got a couple of questions about the study process, and then I've got a comment. The first of which is, have you played around with ultrasound at all in the idea of like measuring the volumes of these ligaments? I just kind of wondered as you were going through and saying, like these are all our elderly cadavers. how functionally that might translate over to younger cadavers. And while I think it probably isn't going to change significantly, it might be interesting to see if the change over time from like 30-year-old female to 50-year-old female I find that to be interesting. So I just interested to see any in vivo kind of processes.
Yeah, absolutely. During ultrasound a little bit, I found some studies where it was reliable at measuring ACL volume, but not so much in terms of LCL and ALL. But I do think in future studies, like the MRI study, I think an ultrasound study in the future could definitely be worthwhile to have a more diverse sample. And I'm definitely interested in the anatomy of the ALL over time, kind of like you mentioned, because I did find 2 studies that looked at the ALL in fetuses, and just to see if it was a solid structure like other ligaments. And it was deemed that it was not a solid structure, whereas the ACL and LCL were solid in a fetus. So they suggest that the ALL kind of thickens as it is affected on by forces as you develop and age, to the point where in these elderly cadavers, it is a solid structure. But I do think it'd be interesting to kind of track its progress and growth over time for sure.
Yeah, as I was looking at your diagrams and your dissections, it would definitely, it seems to me, be difficult with ultrasound to look at LCL versus ALL. I think it would be difficult to differentiate between those structures also from an ultrasound perspective. So that's interesting. And also it'd be interesting to know if that is a structure that is hardened due to stress, is that, if you do sports when you're a kid, does that change, whether or not you've got a good, thick, solid ALL versus somebody who's sedentary through their teenage years or the like. So, and I have one more comment, and then I'm going to let Dr. Wolf have the floor. The other thing, I read a little article today. It was a study that was based out of the VA that talked about people of increased height. So, like they're looking at what are the risks and benefits of being over 6 feet tall. And one of the things that they talked about, being over 6 feet tall or being tall was cardiovascularly protective. But from a perspective of peripheral nerves, they were more likely to have peripheral neuropathy, peripheral ulcers, and those kind of things. And I wondered, as you were saying that, if that was maybe in association with anatomical differences, because they were talking about people who were genetically predetermined to be tall rather than, because being tall is genetics and nutrition and all that other kind of stuff. So I just thought that it was interesting, and maybe an interesting tie-in for other participants, that maybe anatomical differences might be contributing to that peripheral neuropathy, because as things are stretching, that it's putting more tension across those, or if you have bigger, thicker structures, more likely to impede nerves.
Yeah, I also think it'd be really interesting if you look at kind of the rate of growth spurts that people experience, because there's some people who kind of grow steadily and some that have huge spurts of like a foot in a year. So like you mentioned with stretching of the nerves, that'd be interesting to look at.
Agreed. Thank you very much. I really enjoyed your presentation. Thank you.
Thank you.
Yeah, I was going to question along those same lines. So I was viewing the ligament as a living object and was questioning to what extent older, fatter me has a bigger ligament than younger, skinnier me might have, or to what extent, when I broke my ankle and my muscle all atrophied away, to what extent my ligament followed it, especially given that you had, differences with ligament size for that ALL or whatever it was in the males, and you also documented that the males were heavier. So was it possible that their body weight contributed in some way, shape, or form to the size of that? And would you know whether or not the people were sedentary at the time of death, or I should, immobilized at the time of death? And, that could potentially have an impact on something as well, if any of what I'm spewing out here is rationally based.
Yeah, absolutely. I think that it's rationally based. Having a better history of the patients and sample involved could definitely help, like their activity level, sedentary level. I think that'd be very useful if an in vivo imaging study is done in the future. You could collect a better history like that to potentially test some of those differences. In terms of the height and weight, we were initially interested in correlating some of these measurement values with height, but just didn't kind of see that through or include it here today. We just decided to go on the sex differences and laterality difference for to be concise with the manuscript and presentation. But I do think correlations with height and weight and the effect that those have on these measurements is worthwhile in the future.
Well, it seemed to me that weight was particularly likely to affect it, because I for one am carrying the apple shape around proudly, and so that would be above the knees.
Yeah, and based on the literature search that we did, a lot of the correlations just do height, and not a lot, interestingly, with knee ligaments included weight. So that could be something worthwhile, especially like you mentioned, the distribution of the weight in terms of superior to the knee or inferior to the knee.
Ryan, I was very impressed with your presentation. You made that presentation like a true pro, and it was very good in quality, and you had excellent command of your slides, and you knew all your data. My questions are very similar to what Dr. Wolf had asked, relevant to height and weight. I'd like to take it just a little bit deeper in terms of, and I don't know how you do this. You probably know this, and other anatomists and other physicians know this as well, probably. But determining leg dominance, can you explain that to me in terms of clinical explanation of how you go about determining leg dominance? And then once you know that, then I've got a second part to that I'd like to ask.
Mm-hmm. I think determining leg dominance can be kind of tricky clinically. My more sports background leads me to think of an example of like soccer players, in which leg they kick the ball with. But I think just a simple clinical test you could do is some balance test or single leg squat strength test to see which leg you have more balance or have more strength on, in terms of how long you could hold yourself on one leg on right versus left. And then if you have more balance and more strength on one side, I think it could be safe to call that your dominant leg.
Okay, well, you used it in your presentation, and I don't, again, I'm not sure how you come to that conclusion to say which leg is dominant in a cadaver, other than maybe size, or development. My other question to you is height and weight. I can understand the rationale there. Well, you had a sample volume of 41 cadavers, so 82 extremities.
Mm-hmm.
Was there a division or a percentage of different ethnicities or races that you could say had any different set of numbers? Were they all Caucasian, or were some Asians, blacks? Can you share that with us?
I'd have to look back at our information on the individual cadavers.
Yeah.
Just looking at them, there was one African-American donor, and I didn't bother kind of looking specifically to see if that cadaver had any crazy differences compared to the average.
Yeah.
But that could be worthwhile. And in terms of different ethnicities, the rest of them kind of just looked Caucasian. I don't know if there were any specific differences.
Yeah, I'm just wondering about that because the, and again, anatomist and PhD listening, I think that would be an interesting fact to know, relevant to drawing any clinical conclusions. And I don't know, but again, overall, I thought your presentation was very, very good. Nice job.
Thank you. I appreciate that.
Just to reiterate that again, that was a great presentation. Thank you so much, student Dr. Schiller. Thanks for taking the time out of your day to do this. And thank you everybody else who was here and able to join us today. We have 3 more presentations, I believe. So yes, we have 3 more presentations left, and then we are done for the semester, spring/summer journal club, and we'll start back up again in the fall. If you know a student doctor that maybe would want to participate in this, or maybe you're in the audience and you're a student doctor that wants to participate in this, feel free to email me and I can get you set up and we can chat. Other than that, thank you everybody for being here again. Have a great weekend.